Okay, 3, 2, 1. This is part 3 of Integumentary system. I hope I can finish this. I'm aiming to finish this. All right, I can do this. All right, here we go. Skin assessment of newborns assessing jaundice. Mild jaundice is seen in more than half of all newborns. It is important to be able to distinguish when the condition needs to be monitored or has become serious. Newborn jaundice is classified as physiologic or pathologic. Physiologic or pathologic. Which of the following attributes of jaundice are physiologic and which are pathologic? Okay, let me write down some notes. Appears less than 24 hours after birth. Physiologic or pathologic? Patho. If it's less than 24 hours after birth, wait, let's define physiologic and pathologic first. Physiologic means it's normal. Physiologic. Wait. Physiologic versus pathologic jaundice. Without taking medication, it can disappear by itself in about 1 to 2 weeks after birth. Therefore, physiologic jaundice causes a small impact on the baby's overall health. Pathologic jaundice, however, appears within 24 hours of birth, and the baby's serum level of bilirubin continues to rise over time. Okay, so physiologic versus pathologic. Pathology is a medical discipline that describes conditions typically observed during a disease state, whereas physiology is a biological discipline that describes processes or mechanism operating within an organism. So physiology is normal. So less than 24 hours after birth, I don't know. Let me just guess. Okay, so this is pathologic. Versus longer than 2 weeks versus longer than 2 weeks, physiologic. Oh shoot. Versus longer than 2 weeks. That's pathologic. Peaks at day 3 to 5 of life. Like jaundice, right? Oh, it's physiologic. Peaks at 3 to 5 day of life. Oh my god, that forgot physiologic and pathologic requires more intensive monitoring and work. Pathologic requires work. Okay, can result in acute bilirubin encephalopathy. The pathologic bilirubin encephalopathy peaks at 3 to 8 milligram per deciliter. 5 to 8 milligram per deciliter. Okay. All right, let me do that again. Requires more intensive monitoring workup. Pathologic persists longer than 2 weeks. Pathologic peaks 3 to 5 of life. Day 3 to 5 day of life. Physiologic can result in acute bilirubin encephalopathy. Pathologic appears less than 24 hours after birth. That is pathologic. Peaks at 5 to 8 milligram per deciliter. That is physiologic. Okay, move on. Fast fact. Assess a newborn infant for jaundice in natural light. Jaundice can be seen when bilirubin levels reach 5 to 7. Jaundice can be seen when bilirubin reach 5 to 7 milligram per deciliter. Okay, physiologic. All right, assessment of vascularity and bruising. It is not possible to pinpoint the age of a bruise by color alone. A bruise is a contusion resulting from compression or blood trauma to the skin. It differs from ecchymosis, which is a slow leak of blood into the tissues. There has been no evidence based research to support color charts used to date bruises. Blood pigments break down approximately 2 days after the contusion occurs, causing the color to change gradually to a more yellowish tint. The best resource for the aging of a bruise is the reliable patient's history of event. Color changes of bruises. Stage 1, injury occurs, bleeding begins. Stage 2, bruise darkens. Stage 3, blood pigments break down. Stage 4, color is muddy as bruise resolves. Best practices. Applying pressure over a bruise will not cause it to blanch or turn white. Assess all possible bruises to distinguish a bruise from a rash or normal skin variation by checking for blanching. Assessment of vascularity and bruising. Patterns of bruising. Bruises may indicate abuse depending on their location and shape. The areas of reported trauma should be consistent with the bruises. Case study. Tim, a 15-year-old white male whose mother has brought him in because he complains of a chronic stomachache. He's a new patient who seems somewhat passive and depressed. As you examined him, you notice that he has many bruises at different stages of healing, as well as some fingerprint bruises on his shoulders. You casually ask him how he got the bruises. He tells you that he got bruises playing football and wrestling with his brothers at home a few days ago. However, the one sports related incident he describes does not account for the various bruises at many stages of healing. Quick tips. A healthcare professional is one of many professionals who are required to report suspected physical abuse. Question 1. Is it appropriate to immediately ask Tim's mother to leave the room? Yes, definitely. Incorrect. That is a no. You will certainly want to speak with Tim privately. A good procedure is to tell the parent at the beginning of a visit that at some point you will want to speak with the child alone. Then there will be no surprise or anxiety later when you request the privacy. Oh yeah, I took this course before. Okay, the answer is no. All right. Next, question 2. Is it appropriate to ask Tim's mother if she knows how he acquired the bruises? I forgot. Is it appropriate to ask? Maybe yes. And yes, you want to hear her explanation to determine if it is consistent with the bruising and with Tim's explanation. Okay. Question 3. Is it appropriate to ask Tim if he has noticed any pattern to his stomach aches? Of course. Why not? Abused children often develop chronic problems such as headaches or stomach aches in response to abuse. A pattern may exist in Tim's situation. Yeah. Question 4. Is it appropriate to schedule a return visit? Of course, it's important so that you can see the stages, especially since Tim is a new patient and you're unfamiliar with his family scheduling. With his family, scheduling an appointment to review the test results, for example, will give you another chance to interact with him and assess the situation. Question 5. Is it appropriate to speak with Tim privately and explain what he tells you will remain confidential? Of course. Yes, doing so will help establish trust and ally Tim's fears that you will disclose confidential information to his parents. However, if abuse is discovered, mandatory reporting to authorities is required. Question 6. Is it appropriate to take photos to document the bruises? Yes, of course. It's important to document suspicious bruising. Assessment of skin temperature. Check for variation in skin temperature. Differences can be both general and local. Assess for variations in skin temperature. Normal skin is warm and dry, which suggests normal circulation. Differences in temperature should be noted and addressed. Key points. Assess skin temperature with the dorsal side of your hand because it is more sensitive to temperature, dorsal side. Assess changes in any area with both hands to ensure that the variation is the patient's, not your own. Assessment of skin moisture and texture. Normal skin perspires in response to physical exertion. It feels smooth and firm, with even surfaces. The skin's mucous membranes are pink and moist. Features of abnormal skin moisture and texture. Abnormal skin moisture. Diaphoresis may accompany anxiety, fever, and chest pain. Dryness may present as dry, cracked lips or as dry and cracked mucous membranes. An overproduction of sebum and blocked hair follicles can lead to breakouts of pimples. Abnormal skin texture. Abnormal skin texture. Skin may be rough, scaly, dry, or thick. Skin may be very smooth, thin, and moist, but not necessarily oily. Red scaly patches may indicate eczema. Red scaly patches. Skin may be very smooth, thin, and moist. Skin may be rough, scaly, dry, thick. Cradle cap manifests as greasy, yellow-brown patches on the scalp when it is not properly washed. What is cradle cap? Never heard of this word before. Cradle cap. Oh, baby scalp. Ew. Oh. Cradle cap. Okay, that's gross. Continue. Best practices. Abnormally rough, dry skin and sparse hair may lead you to suspect hypothyroidism. Assessment of skin turgor. Normal, abnormal. Assessing skin turgor is an essential part of skin assessment. To determine turgor, pinch a fold of skin under the clavicle, the anterior chest or abdomen so that the top of the skin separates easily from the underlying structure. Assess as follows. Normal skin with good turgor rises easily and returns to place immediately. With insufficient turgor, the skin does not immediately return to place, but stays separated and exhibits tenting. All right, flip the card to learn more. Turgor. The elasticity of the skin often a reflection of hydration status. Key point. Because poor turgor is more common and more prominent in older adult patients due to loss of elastic tissue, check for skin turgor at the sternum, forehead, or inner thigh. Okay. Summary, assessing skin color. Assessing skin color. Key takeaways. In this section, we review the anatomy and function of the skin and the differences in skin due to variances in color, vascularity, moisture, texture, and turgor. Additionally, you reviewed various disorders as they relate to ethnicity and age. Section 3, assessing lesions. Okay, lesions. In this lesson, you will assess the variables of lesions. You will recognize lesion configurations, differentiate between non-palpable and palpable types. Mm, and identify the four types of fluid-filled lesions. Next, you will identify the different types of lesions on infants and children. Finally, you will identify secondary and vascular lesions. Assessing lesions, examination. When assessing lesions, include an assessment of color, size, elevation, distribution, shape, exudate, and consistency. Use the following tips for lesion examination. Tip 1, tip 2, tip 3. Examine lesions, color, and elevation with a flashlight. Wear gloves as you roll. Scrape, blanch, and check lesion temperature and depth. Record the diameter in millimeters of the lesion and surrounding erythema. Best practices. When assessing a newborn, check the entire length of the body for lesions or defects, especially along the spine, head, neck, and bridge of the nose. Assessing lesion elevation, distribution, shape, exudate, and consistency. Learn about assessing lesions in terms of elevation, distribution, shape, exudate, and consistency. Elevation. Is the lesion flat, raised, or pedunculated, connected to the skin, or a stem or stalk-like base? Wow. Distribution. Do the lesions have a symmetrical or asymmetrical distribution? Lesions may be widely distributed, generalized, localized, or specific to an area or regional. Called regional shape. Review the various shapes of lesion shapes below exudate. What is the type, color, consistency, and order of the exudate? Blood and serum, serosanguinous, pus, purulent, mm, bloody, sanguinous, clear, serum, fluid, serous, pus, purulent, sanguinous, bloody. Shapes of lesions. We have iris or target lesion, concentric rings with a central dark or purple papillae inside of a pink macule, oval shaped like an egg, annular round shaped like a coin or disc, and stellate shaped like a star. Wow. Okay, move on to the next. Lesion configurations. Certain lesions have specific patterns. Getting there. Shapes and distributions. Understanding the variations will help you to differentiate the types. Lesion characteristics. Whoa. This is called discrete lesions. Discrete lesions are distinct individual lesions such as insect bites. Okay, and this is confluent configuration, meaning lesions merge together and are indistinct. Generalized lesions, meaning scattered all over the body, as with measles. Okay, next. Number 4, regional. So zoosteriform configuration is also a linear configuration, but the line is along a cutaneous nerve path as seen in herpes zoster. Okay, let's take a video, photo, screenshot. Next, grouped or clustered lesions. An example is herpes simplex. This one, linear configuration. In a linear configuration, lesions form a line as seen in poison ivy or dermatitis. Next, Annular configuration. In annular configuration, lesions form a circle and may indicate ringworm. Okay, next. Polycyclic configuration presents as interlocking circles, as seen in urticaria. Okay, dokes. Next, non-palpable lesions. A lesion is a pathological skin change. Primary lesions develop in conjunction with the disease, wound, or irritation. They can be described as either non-palpable or palpable. Which of the following is an example of macule? And which of the following is an example of a patch? Okay, I forgot the definition of a macule and a patch. I need a scratch paper. Macule patch. Okay. Next, I have a class at 5:30. Macule versus patch. Vitiligo. I don't know. Macule? Oh, it's a patch. Vitiligo. Nevus. Macule. Nevus. Next, lentigo. Vitiligo. Lentigo is a macule. I don't know what lentigo is. Measles, 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 measles. Yes, measles. Cafe au lait? What's that? I don't know. Patch. Cafe au lait. Freckle. Macule. I don't even know. Mongolian spot. It's a patch. All right. Mongolian spot. Okay, let me do that again. Measles is macule. Cafe au lait is patch. Lentigo is macule. Freckle is macule. Nevus is macule. Mongolian spot is a patch. Vitiligo is a patch. There you go. Perfect. Continue. Fast fact. Although cafe au lait macules are a normal newborn skin variation, if 6 or more spots, each more than 1.5 centimeter in diameter, are present, it is diagnostic of neurofibromatosis, an inherited neurocutaneous disease. No, palpable lesions. Examples of palpable lesions include papules, plaques, nodules, tumors, and wheals. Papule, solid, elevated, and circumscribed. Okay, let me take a screenshot. Papule. Next, plaque, plateau-like disc shaped and greater than 1 centimeter. Nodule, solid, elevated, hard or soft, larger than 1 centimeter, and may extend deeper into the dermis than a papule. Tumor, larger than 2 centimeter. Real, superficial, raised, transient, erythematosis, or pale, irregular. Types of lesions. Whoa, there's a lot. Okay. Papule is a papule, lymphoma tumor, wart or mole, papule, nodule, plaque. Here's another one. Ringworm, molluscum, urticaria hives. Ringworm is a plaque, molluscum is a papule, urticaria is a wheal, hives is a papule. Alrighty, next definition, dermis. Dermis is a vascular underlayer that separates the epidermis from the cutaneous adipose layer. Fluid-filled lesions. Primarily lesions that are filled with various types of fluid include vesicles, bullae, pustules, and cysts. Review the following terms before moving on. Bullae, same as vesicle, but larger than 1 centimeter. It is thin-walled and ruptures easily. Friction blisters, second-degree burns, contact dermatitis, pustule, circumscribed, elevated, and activities filled with pus. Examples of pustules, acne, impetigo, folliculitis, cyst, sebaceous cyst, cystic acne. Oh, this is what I have. Vesicle, elevated cavity with free fluid up to 1 centimeter. Clear serum flows if opened. Okay, there we go. Skin lesion on infants. Inspect children's skin for nodules, tumors, lesions. Although in children, many lesions are normal, they can also provide clues to internal problems or disease. A rash found in a newborn may provoke fear or anxiety. Okay, I will continue recording later. Just a moment.